Boa tarde, good afternoon. It is very much my pleasure to be able to be here with you and to have been invited to the anniversary of the very important teratogen information service, the SIAT in Porto Alegre, that Lavinia Schuler and Maria Teresa Sanseverino have been directing so efficiently during many years. I will talk to you about my own subject, which is the fetal alcohol syndrome. I will try to be, for the sake of time, as efficient as possible. I may be going a little bit fast. And I will talk to you about what we know, most of which you probably do know, and also about our research. So, the fetal alcohol spectrum disorders is a term that is an umbrella term for a complex range of brain injuries. And remember, this is real brain damage caused by prenatal exposure to alcohol. You guys will, most of you know about fetal alcohol syndrome. We realized many years ago that most children that are exposed to alcohol and that have problems do not have the facial features. This is why the term fetal alcohol spectrum disorders was designed. This is the #1 preventable cause of intellectual and behavioral impairment. As I told you, the fetal alcohol syndrome, the classic condition with some specific facial features, is only the tip of the iceberg. And in fact, most of the iceberg that's underwater is a full spectrum of learning and behavior disorders that are not associated to any physical impact and that are clearly a consequence of alcohol. What is most important is that the prevalence of this disorder is extremely high. And a very recent study out of my department determined that in 4 communities in the United States, the prevalence can be between 2 and 5%. So to 24 to 43 per 1,000 births. So more common than autism. And just realize the amount of resources that autism has for rehabilitation, for therapies, for social support in comparison to the children that are exposed to alcohol. What are the reasons for this? Alcohol is legal. More than 50% of women in reproductive age will drink. 1 in 10 pregnant women will use alcohol, but more than 50% of pregnancies are absolutely unexpected. Therefore, at least at the end of the pregnancy, it's very common that a young woman will have binge drinking or even get drunk, even if she is not an alcoholic. And certainly binge drinking, having huge levels of alcohol in blood, can be extremely damaging to the developing brain. But certainly drinking every day during pregnancy is the main risk factor. When we go look at the fetal alcohol spectrum disorders, there is 4 dimensions that we need to assess. 1 is the growth. 2nd is the dysmorphology, the different facial and other features, including a small head. Another one is the neurocognitive or neurobehavioral profile. And last is the maternal interview. And I have put this one in red because, as you can imagine, having a truthful revelation by the mother that she drank a lot of alcohol in pregnancy doesn't happen that often. Children are often adopted out of the family. Mothers, if they drank, may be absolutely ashamed of it and may not want to talk about it. And the stigma surrounding doing something that may have damaged your child certainly makes it that knowing for sure that a woman drank alcohol is difficult. In fact, because we are not often sure, This is the main reason why the dysmorphic features and also the neurocognitive profile are extremely important to define which children are likely to have been exposed to alcohol. And there is where much of the research occurs. Besides the search for a biomarker for something in the baby's tissues that could tell us, yes, mother drank during pregnancy. Just to show you some prevalent studies so you realize this is not only the United States. In South Africa, in a region where the agricultural workers were actually paid with wine in the past, the frequency of the fetal alcohol syndrome, and the fetal alcohol spectrum disorders was probably around 7 to 9%. In Italy, in a completely different situation, in a middle-class region near Rome, where there are wine country and a lot of wineries, the frequency was 2 to 4%, very similar to the American study. And of course, we do have some places where the prevalence is extremely high, such as these children in an orphanage in Russia, where the prevalence obviously could be as high as 12%. Therefore, this is a very common disorder. However, it is under-recognized. Only 11% are diagnosed by age 6. It is not in the radar of clinicians. There is a lot of stigma. One thing is, if a pediatrician has a woman that is obviously a drug user and an alcoholic, but if the mother is a normal lady, the pediatrician will most of the time fear asking about any exposures in pregnancy, stigma, and under-recognition is the worst in this disorder. In addition, most children will not have the facial dysmorphology. The neurobehavior phenotype, that is the learning and behavior problems, are not that specific. So they have a great overlap with attention deficit hyperactivity disorder, with autism, with oppositional defiant disorder, and certainly the diagnostic criteria are being better defined every day, and this is again a subject for research. In addition, we did talk about stigma and reluctance of both the interviewer and the mother, and this is why interviewing with a particular techniques can be very useful. Very often the birth history is unknown, and as we said, there are no biomarkers. The most important thing, however, that you must realize is that many teratogens, many of the medications and drugs that will affect development will do it only during the embryonic period until 8 or 9 weeks. However, alcohol, which is mostly a teratogen for the brain, will be a teratogen from the first day of pregnancy to the last day of pregnancy, which means that anybody in their practice, in their personal life, that knows someone that is drinking should have them stop drinking, even if it's at 8 months of pregnancy. That will be a huge benefit for the patient. Let's start talking about the features. The features in severe cases can be as dramatic as growth deficiency, which can manifest very early in pregnancy or can manifest much later. Then there are some physical features, some facial features that are very specific. And those are 3. The short opening of the palpebral fissures, and we will talk about this a lot more. The smooth philtrum, so this area between the base of the nose and the upper lip that has 2 pillars and a groove in the center, is called the philtrum pillars, and the philtrum becomes smooth. There are no pillars, there's no groove. The upper lip, in addition to that, the vermilion border of the upper lip, which normally can have a very significant Cupid's bow configuration, will be thin and will become linear. So these 3 features define the face of the fetal alcohol syndrome in addition to a small head and growth deficiency. What is most important, and you must realize, is that these features are really quite specific. They occur in every race, in every ethnic group. Obviously, children that are African in origin will have thicker lips. But as you can see, the philtrum is just as smooth and the upper lip becomes linear, loses the Cupid's bow. This was, interestingly, only reported in 1973 by Ken Jones and by a French doctor a few years before, Lemoine, in a regional journal. But if this had not been published in the Lancet, we would still not know, maybe, that alcohol was extremely damaging to the fetus. And it's amazing that history has ignored this fact, even though there are even references in the Bible. So, you know, the face in the fetal alcohol syndrome is different. We will talk a little bit about these 3D images, but we do know that even with computer models based on 3D images, we can see how in children with fetal alcohol syndrome, the mid-face will be a lot more flat, the area of the philtrum will lose all its volume, the palpebral fissures will be shorter. So more and more, we are tending towards an automatic recognition of the face in the fetal alcohol syndrome. Is it, we can compare it against controls. These are heat maps, and the blue means it's less volume in these areas, more volume in these areas in patients with FAS than in controls. Of course, even though I believe any pediatrician could diagnose the fetal alcohol syndrome, there are some genetic syndromes that have some overlapping features. So there should always be a critical eye looking at these children and realizing that they do not have additional features that could suggest a syndromic diagnosis of genetic etiology. What's most interesting is that this has been proven in the laboratory in animal models, and that the mouse has the exact same thing. An underdevelopment of the frontal and prefrontal cortex with a narrow forehead, short palpebral fissures, a small nose, a small mid-face, a long upper lip, exactly like the child. So, and the reason is that the forebrain and this triangle in our face, this triangle in our face, all come from neuroectoderm, from the cranial neural crest, and they are not derived from mesoderm. So the effects that alcohol has over neural precursors are also manifest in the cells that will populate the face through the neural crest migration. This is why we could say, oftentimes, the face predicts the brain in the fetal alcohol syndrome, and the more dysmorphic the child is, the more likely that the cognitive deficits will be more severe. So FASD is an umbrella term that includes the fetal alcohol syndrome, that includes what we will call the partial fetal alcohol syndrome, but also some birth defects and some alcohol-related neurodevelopmental disorder. Look at this. So basically, when we know that confirmed alcohol exposure is absolutely essential when there are no physical features. So interestingly, if a child has very clear physical features and we don't know for sure that the mother drank, we can establish a diagnosis of the fetal alcohol syndrome or the partial fetal alcohol syndrome, which, as you can understand, make the value of these facial anomalies extremely important, because they can be a substitute for our knowledge of exposure. And therefore, recognition of these features is of utmost importance and should be very specific. Growth retardation is specific of the full fetal alcohol syndrome and is not that frequent except in children of very severe alcoholic women. CNS anomalies is pertinent to all, except some birth defects that we know can occur more frequently. Very early embryonic defects, heart defects, limb defects, eye defects that may not go along with the other features. But it will be difficult to prove that they're actually caused by alcohol. So the most important thing, as you can see, is the 4 dimensions, which are alcohol exposure through an interview, growth, facial anomalies and brain size, and then cognitive and behavioral anomalies and some birth defects. The brain can be extremely small, so it really is a matter of the amount of neurons that were killed. We know that alcohol leads to apoptosis, to autophagy, and to destruction of the developing brain. We know that there are structural deficits, such as abnormalities of the corpus callosum that is interrupted, thin, dysgenetic. Also cerebellar hypoplasia. We know there are seizures in more than 20% of patients, and there can be a baseline abnormal electroencephalogram. And little by little, the neurobehavioral phenotype is better and better defined. For the first time in 2018, the DSM-5, as you know, it is the catalog of mental disorders that psychologists and psychiatrists use in their practice, has for the first time included this category, neurodevelopmental disorder related to prenatal alcohol exposure. And even though non-specific, you do need alcohol exposure for sure, but there are at least 3 domains. Impairments in neurocognitive functioning. Interestingly, most children have normal intelligence, have an IQ that's above 70 points. However, they will have very specific learning problems, such as working memory, such as retention, attention, etc. The second is an impairment in self-regulation. These children can be aggressive, can be hyperreactive, can have all kinds of sensorial abnormalities. They can be overwhelmed by noise, by light, by crowds of people. And finally, they certainly, even if they can have normal intelligence, they have huge problems in communication, socialization, understanding others, understanding humor, being empathetic, so adaptive functioning. So little by little, the researchers are defining this profile much better so that we will be able to recognize every one of those children as a differential diagnosis, as I said, of ADHD or others. The one thing you should always remember is FASD is a brain-based disability with behavioral symptoms. Children can sometimes seem mean, evil. They are not. It's not that they don't want to do things. They cannot. Their brain is not normally developed. So, in summary, fetal alcohol spectrum disorders are frequent. There's multiple diagnostic systems that are very discordant, and there's under-recognition. They all use 3 axes. We know, unfortunately, that in spite of how important these physical features are, there is disagreement in the evaluation, no consensus, and we will talk about it in a minute. And just realize that the physical features can be so characteristic that overall, it's mostly the kids with physical features that will be diagnosed, so we need to do it right. So here comes the research. We are all in the what we call the consortium, the collaborative initiative for the fetal alcohol spectrum disorder, that is a consortium, a research consortium by the NIH. I will first talk to you about our work, Dr. Jones and I, and we are the dysmorphology core. We are the diagnosticians of every case that goes into any of the research projects. But in addition to that, we have to further develop and refine a telemedicine program, and we have to better define the physical features. So what are we doing? So what we are doing, as you know, the examination techniques are a hard ruler, where you need the precise angle, a comparison of the philtrum and the upper lip with the philtrum guide that has 5 photos. This was designed by Susan Astley in the University of Washington. And then with those, to try to get to an agreement. We know there are other features that are seen, some contractures in the hands, some anomalies of the hands, some ptosis of the eyes. And, you know, the idea is to be able to evaluate them all. Here we have children of different sources with small palpable fissures, with a small philtrum in the upper lip, with ptosis and small palpable fissures, with the huge smoothness of the philtrum, and then these contractures, these abnormal creases. Okay, so we want to recognize these features objectively. So what happens? We did a study, Ken and I, trying to see whether we were able to observe through telemedicine, using first a telemedicine device, but also just an iPhone and an iPad, and whether we were able to see well, to determine well what the features were face-to-face and then through telemedicine. So what we do see is that using the kappa coefficient, most of the features are in the almost perfect range of concordance, but some are not. So for example, 1 millimeter in the measurement of the palpebral fissures can actually change the diagnosis. And for the other features, there are some features such as mid-face hypoplasia, which are so subjective that there is clearly disagreement. So we are working on trying to make this more precise and more objective. So what we realize is that we are concordant 90% of the time, the two of us. But interestingly, we are discordant when we assess face-to-face the patients, and our concordance is only 88%. And this is because the features are not very well defined, and also because there's no good ways to measure objectively. So what are we doing? We have designed an app that with the iPhone can take a 3D photo, and then we can measure the palpebral fissures with this device. The concordance between Ken Jones and I, when we do it this way, is much less than 1 millimeter, and we basically never change the diagnosis due to a discrepancy. So more precision in the evaluation of these features. Trying to be more objective. So before we were comparing the philtrum in the upper lip with 5 pictures. Now we are able to actually move a whole continuous scale of a philtrum and an upper lip to decide where we stop. Again, the concordance of Ken and I is much greater than it was before. So, and most amazingly, we can take a 3D picture and we can look at it in an Oculus goggles, and we can see the 3D picture and we can evaluate the patient in 3 dimensions being away. So that is very important. So this is the consortium, the CFAS consortium. I will try to do this in 5 to 10 minutes. I know I am being late, but the purpose of the consortium really is to try to develop and to increase diagnosis and to learn more about the fetal alcohol syndrome. But there's several things that I would like to tell you. There are, we want to know about the genetics, the biomarkers, the health, the interventions, the screening. But it is interesting. We want to employ e-health technologies so that our applications are more broadly disseminated. And this was before COVID. As you can imagine, after COVID, things even are more relevant in that arena. So let me give you some approach to the research that other researchers in the consortium are doing. So Sarah Matson is the psychologist. She has designed a decision tree to be able to predict whether children, based on physical features and neurobehavioral features, are much more likely, what the percent likelihood is that there was alcohol exposure if we didn't know, so that we can treat the child as FASD even without knowing about the exposure. Okay, but most amazingly, she has now developed some online testing. So the patients fill questionnaires online, but the child can even do some neuropsychological tests online, which obviously makes it much more available because, as you know, good psychometrists are not that frequent. So our colleague Christina Chambers, who is probably one of the most important researchers in the world in FASD, has worked in the Moscow region, but mostly in Ukraine, and she's studying all the prenatal factors, ultrasound anomalies, early predictors of FASD, maternal nutrition, supplementation with vitamins, etc. Our friend Claire Coles from Atlanta is studying something that we really don't know, which is what happens to the adults. How are the adults? And what we are finding is that these adults have much more cardiovascular risk, have much more, interestingly, they can develop obesity. And they are overall less able to care for themselves. And they have all kinds of pains and aches and rheumatologic problems that need to be studied. But we are getting these questionnaires from these adults, and it's extremely interesting. Then, obviously, genetics, right? So we want to know whether there are genes that predispose to have a very severe phenotype from being exposed to alcohol in comparison to genes that would be protective, right? And we are doing, she is doing whole exome sequencing for that. Then we have our colleagues from the University of Oxford who are developing automatic measurements, or automatic 3D techniques to be able to evaluate the face. And again, to be able to predict the likelihood that the face is due to alcohol without knowing the exposure. And this is also extremely relevant. Other people are working in the genetics in animal models, in cell models and animal models, and using transcriptomics and all kinds of omics. And for example, there are two very relevant results, or three these days. One is we know that it involves the sonic hedgehog pathway, and that the primary cilia is completely altered in when exposed to alcohol. And we also know, and this is also important, that cannabis and alcohol can act together and can impair things. So cannabis, which is used more and more, especially in conjunction with alcohol, may be very negative for the developing brain. And certainly this is the image where the eye is much, much smaller when both exposures are combined. Then, interestingly, we're talking about what we really need, which are interventions for the patients. How can we help them? Well, our two colleagues in New York State have developed an app which is a remote intervention. And it's called Families Moving Forward Connect. And this app takes you through a learning process of 3 months where you get information every day. You get cases, you get information on education, problems with the law, drug addictions, how to manage the behaviors, how to improve their learning, etc., and how to cope with it as a family. So, of course, again, knowing the number of therapies and the access that people have, this is extremely important. Finally, there are researchers that are studying immune function. It does seem like these people get a lot more often sick of usual infections. And we have our friend Jeff Wozniak, who is studying the connectivity of the brain. So with functional MRI, with tractography, within the Human Connectome Project, we are being able to define what is it exactly that happens in the brain and why. And that may even lead to some therapeutic targets. There's also more research on biomarkers for FASD in single cells, and it seems like there are epigenetic changes that may define the signature of FASD. Finally, there are effects on the microbiome that these days we could not be forgetting about the microbiome. And finally, and this is a very interesting study that we are performing with Alison Motri, we are exposing mini brains, cortical organoids, to alcohol. And we are able to see in that model all the genes that are overexpressed, underexpressed, and all the cells fates, why there is more apoptosis and autophagy, etc. So basically, the fetal alcohol syndrome spectrum disorders are frequent. We should improve our mode of diagnosis. We are conducting research to improve recognition, to give greater access to the patients for diagnosis, both physical and neurobehavioral, and for intervention. We are trying to make those findings more specific, and we are also trying to investigate all the mechanisms, also to know if there are any therapeutic targets. So thank you very much. I really hope you enjoyed this talk, and I very much say congratulations for the success of the SIAT once again. Thank you.